Welcome back. So when we talk about traction, we want to first define mechanical energy. Mechanical energy is the energy possessed by an object due to its motion or position. And we know that we have both kinetic energy, which is that energy of motion, and then we also have our potential energy, which is the stored energy of motion. So based on Prentice's definition, in all instances in which work is done, there is an object that supplies the force to do the work. So in this case, the traction unit is applying the force. When the work is done on the object, which is the patient's spine, the object gains energy. This energy acquired by the object upon which work is done is known as mechanical energy. So this is how we define it in traction. So traction and mechanical force is applied to the body. It separates the joint surfaces. It elongates the surrounding soft tissues, and we know that we can apply this manually or mechanically. The different effects of traction are joint distractions, which when we talk about the joint surfaces, we're primarily talking about the epiphyseal joints, also known as the facet joints. We also get a reduction in disc protrusions. We get stretching of the soft tissue. We get relaxation of muscles and muscle spasms. We mobilize the joints, and we reduce pain through different pathways, either the sensory afferent or the motor efferent pathways. So here's a nice diagram that's in camera and that talks about your spinal anatomy, which I know you guys went over in your pathology class as well. So basically you have your vertebral bodies here, and we know we have 5 lumbar vertebral bodies in most people. There are a few people that are anomaly where there might be a 6th lumbar vertebrae, which will cause some different mechanical issues for you. You have the intervertebral discs. In between those are shock absorbers basically, and they're created and consist of the nucleus pulposa and the annulus fibrosus. I'll try and see if I can get some jelly donuts for you guys so we can kind of look at that concept of how that works. Then you have the epiphyseal joints here, right in here, which also, as you can see in this, I call the facet joints, but primarily you're going to see them called the epiphyseal joints in most literature that you read as far as research articles. And then we have the spinal nerves coming out of that intervertebral foramen, which are these little spaces here, right? So you have a couple places where you can get nerve compression, and we'll talk about that in the next few slides, all right? So joint distraction, what is it? It's a separation of 2 articular surfaces perpendicular to a plane of articulation. So you get the distraction of the epiphyseal or those facet joints. It reduces compression on the joint surfaces and widens that intervertebral foramina, which thus reduces pressure on the spinal nerve. So if we look back on this, if we see that we do some joint distraction, right, perpendicular, you can see how it increases the space here. It's going to increase the space here as well as at the facet joint, which thus that's going to decrease the pressure on that nerve root that's coming out of there. That, you know, when we get that referred pain down the leg with the lumbar spine, if this was happening in the cervical spine, we'd be getting that referred pain down the arm. So by doing that traction or distraction, we open up the spaces both here and here and here that reduces some of that compression on that nerve root and reduces the patient's symptoms, which is a good thing. We also, with traction, get that reduction of disc protrusion. So they theorize that you get this clicking back of the disc fragment. That's due to this intradiscal pressure that happens with traction that increases the tension of that posterior longitudinal ligament as well. So you can see that here in this diagram. And it's really important for you to know when you're doing traction that you're only wanting to do this on disc fragments that are still attached. You don't want to be doing this on floating disc fragments, because then the traction is unpredictable and you can cause some pretty adverse, severe pain for that patient. Okay. The effects of that disc protrusion reduction, you get reduced symptoms in your patient's local back or neck pain, and they also get reduction of the radicular spinal symptoms that we talked about, that referral down the leg or down the arm. So that's a really nice effect from the traction. You also get soft tissue stretching depending on the parameters that you use that we'll talk about later. You get an increased length of those soft tissues. So the muscles, the tendons, the ligaments, all elongates the spine. You get increased distance between the vertebral bodies and the epiphyseal or facet joint surfaces, which increases your joint mobility. You also get muscle relaxation depending on the parameters that you use. This will facilitate relaxation of the paraspinal muscles through pain reduction. With intermittent traction, that change in muscle tension produces relaxation by stimulating the Golgi tendon organs to inhibit alpha motor neuron firing. So you can think of that the same as when we're doing the joint mobilization in our orthopedic class. You're getting those oscillatory responses, and so that's kind of how that works. If we do static traction, we're going to get more of that sustained reaction, so you're going to get a depression of the monosynaptic response caused by the stretching muscles for several seconds, and you also get that reduction in pain. We also can get joint mobilization from traction. It increases through the stretching of that soft tissue structures with the high force. With the low level force, we're getting that oscillatory motion that we talked about, like maybe with those joint 3 grade 3 joint mobs that we're doing on peripheral joints. You can get the same thing with the lumbar spine or the cervical spine. That's going to stimulate either the mechanoreceptors that decrease the pain by gaining the afferent transmission of pain stimuli. And if you're having a hard time remembering that the sensory is the afferent pathway and the motor is the efferent pathway, sometimes I just use the acronym SAME, S-A-M-E, and so sensory is the afferent and motor is the efferent pathway. I was just listening to a study on memory and how some people can memorize things better and remember things, and it turns out through these studies that they've been doing recently that we all have the capability of memorizing to the same level. It's just using different strategies to help us do that, and then we can retain it, and sometimes using acronyms helps with that. That's a different type of memory strategy for you, so I hope that helps. So we're going to stop right there.